We have an excellent lineup of speakers today, and our first presenter is Dr. Marissa Desimone, who will be providing an overview of CF-related diabetes. Dr. Marissa Desimone was born in Syracuse, New York, and is a graduate of Lemoyne College. She obtained her medical degree at SUNY Upstate Medical University. Her residency was at the University of Pittsburgh Medical Center, where she also completed her fellowship in endocrinology, diabetes, and metabolism. She currently practices in Syracuse at the Joslin Center at SUNY Upstate Medical University. Dr. Desimone has particular interests in the use of technology for the delivery of healthcare and endocrine complications of cystic fibrosis. She has been involved in the care of patients with CF since 2014. In addition to her clinical practice, she is the director of the endocrinology telemedicine program and has been practicing telemedicine for the past 9 years. In her free time, she enjoys reading, the outdoors, and spending time with her husband and 2 children. Please welcome Dr. Marissa Desimone.
Hi, my name is Marissa Desimone, and I am an adult endocrinologist at SUNY Upstate Medical University. Today I'm going to be discussing cystic fibrosis-related diabetes. I'd like to thank the moderators who invited me to participate. I have no relationships to disclose that are related to this presentation. So the clinical course of cystic fibrosis has really improved dramatically. Patients are now living to an average age of 44, and this is a dramatic improvement, and it's likely to increase with the improved life expectancy that's expected with modulator treatment. Unfortunately, as patients age, they accumulate additional extrapulmonary complications, and one of the leading extrapulmonary complications is diabetes. Cystic fibrosis-related diabetes is the most common comorbidity in adult CF patients, but it's seen across all ages. Approximately 2% of children, 20% of adolescents, and 40 to 50% of adults can be affected, but up to 80% of adults with severe mutations can develop cystic fibrosis-related diabetes. It's clinically distinct from both type 1 and type 2 diabetes and is primarily a disease of insulin insufficiency. It's been shown that there's decreased and delayed insulin secretion, as well as fatty infiltration and fibrosis of the pancreas and loss of alpha and beta cells. There is also fluctuating insulin resistance, which can vary with the health status and medications of patients. Things like pulmonary exacerbations and glucocorticoid treatment will increase insulin resistance. Risk factors include being older, having pancreatic exocrine insufficiency, being homozygous for delta F508 mutation, being female, having a family history of type 2 diabetes, as well as liver disease. Clinical symptoms can be things like failure to gain weight or weight loss, having poor growth velocity, delayed puberty, an unexpected decline in pulmonary function, as well as increased mortality. The decline in BMI can be seen up to 6 years prior to the diagnosis of CFRD, and we know that there is a positive association with nutritional status, BMI, and lung function and survival. So this is very important to pay attention to. So how should we screen our patients? Well, in healthy outpatients, the recommendation is to do an annual 2-hour 75-gram oral glucose tolerance test. And this is outlined in the position statement by the American Diabetes Association, as well as the International Society for Pediatric and Adolescent Diabetes. Glucose tolerance test results correlate with clinically important CF outcomes and can identify patients who benefit from insulin therapy. It should be done fasting in the morning during a period of stable health. If it's abnormal, it should be confirmed on a different day. The recommendations are to start at age 10 at the latest, and if your patient has symptoms consistent with diabetes, you don't need to repeat it. What about in other circumstances? We know that hyperglycemia during acute illness is common, and it can last up to 2 to 6 weeks after exacerbation. Screening should still be done during acute illness and when patients get pulse steroid treatment. It should also be done in patients who are getting continuous enteral feedings, who are pregnant, or who are getting a transplant workup. Hyperglycemia that persists beyond 48 hours in the setting of acute illness tends to recur and is associated with an increased morbidity and mortality. That's why we should be screening patients when they're sick. So this is just a summary slide showing the different situations in which you would screen for CFRD. For healthy outpatients, we've already talked about the oral glucose tolerance test. However, if you happen to catch a fasting plasma glucose that's greater than 126, if you check an A1C and it's greater than 6.5, or if a patient has a random glucose greater than 200 with symptoms, then those can all be used for the diagnosis of CFRD. Of course, they should be repeated with the exception of random plasma glucose that's high with symptoms. For patients who are on continuous drip feedings, diagnosis can be made based on a mid or immediately post-feed glucose greater than 200. For patients who are acutely ill, you want to document hyperglycemia beyond 48 hours, and that can be defined as a fasting plasma glucose greater than 126 or a 2-hour postprandial greater than 200. And for patients who are pregnant, they should undergo oral glucose tolerance test. However, oral glucose tolerance test in pregnancy has different cutoffs compared to non-pregnant adults. These are the OGTT categories, and again, this applies to non-pregnant adults. A normal glucose tolerance is a fasting plasma glucose less than 126 with a 2-hour plasma glucose less than 140. Impaired glucose tolerance is when the 2-hour glucose is greater than 140 to 199. CFRD without fasting hyperglycemia is a 2-hour plasma glucose greater than 200. And of course, if you happen to find fasting hyperglycemia, you do not need to do the OGTT. Now with CF patients, we are also checking a 1-hour value. And if that is greater than 200, but the 2-hour value returns to normal, that's diagnostic of indeterminate glycemia. And all of these categories are depicted here on the right. So when are patients diagnosed? Well, diagnosis is when a patient first meets criteria, even if their hyperglycemia later corrects. Dating from this point correlates with microvascular complications and survival data. And it's possible that this may change with modulator therapy, as we are hoping that this may modify the course of disease, especially in those patients who might have early diabetes. It's important to remember that very few CF patients have a truly normal glucose metabolism. Impaired fasting glucose, impaired glucose tolerance, and indeterminate glycemia all predict CFRD, and impaired glucose tolerance and indeterminate glycemia are common. Early onset CFRD has been described in prepubertal CF patients. Up to 28% of patients aged 3 to 5 will have abnormal glucose tolerance, and 33% can have abnormal glucose tolerance by ages 6 to 9. And this is associated with worse pulmonary function if it is not diagnosed. Children who are identified early, however, will not have a decline in BMI and FEV1 with CFRD onset if they are treated, and that really suggests a benefit to screening at age 6. This is done at some centers across the country and could be helpful to identify children early. OGTT does have some limitations. The cutoffs are based on adults who are at risk for type 2 diabetes. It can be quite cumbersome and there can be a lot of resistance to getting this done. And OGTT results can fluctuate. And because of these limitations, there's been great interest in finding other possible screening tools. So one thing that's been looked at quite a bit is A1C. Unfortunately, A1C at the onset of CFRD can be normal and has a poor correlation with blood sugar values. A1C can miss CFRD and abnormal glucose tolerance. In one study by Burgess, A1C cutoff of greater than 5.8% was evaluated to see if it could be used for screening. And in that study, they estimated that there was a sensitivity of 94% and a specificity of 53% for predicting CFRD. However, in a different study done by Boudreau, also using that same cutoff, the sensitivity was only 68% and the specificity 61%. And in that study, they estimated that 32% of their CFRD diagnoses would have been missed. In a study done by Gilmore, they used an A1C cutoff of 5.5%, which had a sensitivity of 92%, but a very poor specificity of only 24% to predict CFRD. And again, this does not pick up abnormal glucose tolerance. So even though A1C cannot be used for screening, it can be used for follow-up. A1C does correlate with average blood glucoses. This was looked at by Chan in 2018. And in that study, they looked at 93 CF patients with an average age of 14. 25% had CFRD on insulin with an average A1C of 5.7% and an average daily glucose by CGM of 116. So hemoglobin A1C is not considered sufficiently sensitive for screening. It does not pick up abnormal glucose tolerance. We also do not use fructosamine, urine glucose, random glucose levels, continuous glucose monitoring, fasting plasma glucose, as it will miss half of patients with CFRD, and self-monitoring of glucose with home meters. Another tool that's been evaluated to look for CFRD is continuous glucose monitoring. So continuous glucose monitoring can pick up a lot of glucose abnormalities, even those with normal glucose tolerance on oral glucose tolerance test. And this is probably because under real life conditions where dietary intake is quite variable, patients can have a very high carb intake. And so it's not surprising that CGM glucose levels would be higher than those seen on a standard 75-gram oral glucose tolerance test. That being said, OGTT is still better at predicting the future risk of CFRD. And CGM is not currently accepted for the diagnosis of any type of diabetes. And so it's not used at this time. However, if longitudinal data was found to show that abnormal CGM readings could predict clinical decline, and if we could say with certainty what CGM parameters we should be looking at, it's possible that the definition of the diagnosis of CFRD could change. The real key here is whether or not CGM could predict morbidity and mortality, which is what OGTT does. If abnormal CGMs can predict that clinical decline, then it's possible they could be used for screening. So what are our goals of management? Well, the primary goal in managing patients with CFRD is to improve their weight, their protein anabolism, their pulmonary function, and survival. That comes really before glucose control. And that's one way in which managing patients with CFRD is very different than managing patients with type 1 or type 2 diabetes. We are, of course, interested in preventing complications as well. Complications in this population are primarily microvascular. There are a few reported cases of macrovascular disease. It's important for patients with CFRD to maintain their high-calorie diet. CFRD does not alter dietary recommendations, and we almost never restrict calories in these patients. The goal is for them to maintain their BMI. It's important to encourage aerobic activity in patients. And modulator treatment may change guidelines as obesity is becoming more common. But as of now, this is what the guidelines state. Insulin is the only recommended treatment for patients with CFRD. It improves weight, protein anabolism, pulmonary function, and survival. This is a picture of a little boy who had type 1 diabetes. And as you can see, he was incredibly sick and cachectic. After being given insulin, he was nice and plump and healthy. And that is because of the anabolic properties of insulin. Insulin has also been shown to reduce pulmonary exacerbation. And it's important to remember that some patients may only need treatment during acute illness. Another big question in management of CFRD is whether or not other medications could be used. And there are a few that have been evaluated in the literature. Repaglinide has been looked at for treatment of CFRD. Unfortunately, this has no sustained favorable effect on BMI, and so it's not recommended for use. GLP-1 receptor agonists have also been evaluated, and it's true that they may improve glycemic measures. However, semaglutide is shown to result in weight loss, and exenatide has been shown to delay gastric emptying, which could be problematic as CF patients in general can have delayed gastric emptying even without CFRD. So currently, none of these medications are recommended for use. Other oral agents are not as effective as insulin for anabolic purposes, and there are CF-specific concerns with some oral agents, with things like comorbid liver disease, hypoxia, pancreatitis, and GI side effects, which could prevent their use in this population. When monitoring your patient, it's important for them to check their blood sugars. They should check their self-measured blood glucose at least 3 times daily. CGM has been validated in monitoring in CF patients. It's important to individualize glucose goals for every patient, and you can use your A1C for monitoring glycemic progress. Microvascular screening should be done 5 years after diagnosis or at the onset of fasting hyperglycemia. Annual lipids should be checked for patients who have pancreatic exocrine insufficiency, obesity, a family history of coronary artery disease, or who are on immunosuppression after transplant. And of course, all of the normal routine things done for this population: weight, BMI, lung function, hospitalizations, etc. Regarding insulin therapy, it's important to come up with a flexible dosing regimen for your patient. They may need basal, bolus, or both. It's possible that patients may only need to bolus for certain meals of the day and not all of them. And for patients who tend to graze throughout the day on frequent small meals, it's possible that a once-a-day basal insulin alone may be sufficient for them. As far as starting doses, a good place to start would be with a total insulin daily dose of 0.5 to 0.8 units per kilogram. And for patients who have been taught how to carb count, they could use as a starting dose 1 unit for every 30 grams of carbohydrate and 1 unit for every 50 milligram per deciliter of glucose above target. The real goal is to maximize insulin and glycemic control without provoking hypoglycemia. There are multiple different insulin delivery options that are available to patients. Vial and syringe is very commonly used still. However, insulin pens can make dosing much easier and can also help to improve accuracy. And of course, insulin pumps are also available to patients if they are interested, and insurance authorization can be obtained. Regarding insulin pump therapy, there are currently 3 different options that are available. There are the Medtronic pumps that are available. There's the Omnipod. This is a tubeless insulin where a pod that contains insulin is inserted, and the controls are on a separate PDM that can be carried in the pocket or in the purse. And then there's the T-Slim pump. Some benefits to pump therapy include the need for fewer injections. They allow the patient to adjust insulin with exercise and when they're sick. It becomes easier to cover snacks for patients who graze. You can provide custom boluses based on the macronutrient content of your meals. Pumps can help to reduce hypoglycemia, and they have computer software available for blood sugar analysis. Continuous glucose monitors can also be very helpful. For a continuous glucose monitor, there's a small transmitter that sits on top of the skin and a cannula that rests in the interstitial fluid, which senses what the glucose is. This information is then sent to a receiver, which the patient looks at to tell them what their blood sugar is. And certain continuous glucose monitors can also tell the patient what the trend of expected blood sugar is. So CGMs have been validated in patients with CF. They can result in fewer finger sticks. They can help patients see what their glucose trends are. They can provide alerts for high and low blood glucoses prior to them happening so that the patient can initiate treatment. They're generally worn on the abdomen or the back of the arm, but unfortunately they are not universally covered by insurances. And again, just to review, CGMs are valuable for the management of existing diabetes, but cannot be used for diagnosis. Depending on what CGM you're using, they can last anywhere from 7 to 14 days on the body and can really help patients with their quality of life. There's also the hybrid closed loop systems. So with a hybrid closed loop system, the patient is wearing an insulin pump, which is delivering insulin, and they're also wearing a continuous glucose monitor, which is sensing what their blood sugar is. The continuous glucose monitor transmits the blood sugar information to the pump, and then the pump, using computerized algorithm, can adjust the insulin to try and maintain the blood sugar within the target range. These pumps can be very helpful in glucose management and can help to prevent hyper and hypoglycemia. And this is just an example of the Medtronic hybrid closed loop pump, which was the first one on the market, but Tandem also has a hybrid closed loop system that is available at this time. So some future directions to think about. One big question is, should patients with CF with prediabetes be treated? And if so, what are the appropriate diagnostic cutoffs? We know that indeterminate glycemia is associated with decreased lung function and that impaired glucose tolerance is associated with a decline in BMI. And small studies have shown a benefit to insulin treatment. There are currently trials underway being done to evaluate the benefit of treating prediabetic patients with insulin and DPP-4 inhibitors. Another question is, what is the CFTR modulator's effect on CFRD? We know that CFTR affects beta cell function, although it's not completely clear whether that's a direct or indirect effect. But insulin secretion has been shown to improve in young patients with CF who have a gating mutation who were treated with ivacaftor. And that really indicated that insulin secretion defects in CF may be reversible. It's unknown at this time if modulators can prevent or treat CFRD, and I think that this will be an area of much interest and research moving forward. That's all I have for today. I'd like to thank you for your time and your attention. I would also like to thank my mentors, Dr. Tony Moran and Amit Mohir, for their guidance and support, as well as the CF Foundation for their grant supporting endocrinologists who treat patients with CF. Thank you.
Thank you, Dr. Desimone, for that excellent presentation. Our next speaker will be Crystal Kobasic. She is the Program Coordinator from the University of California, San Francisco Diabetes Teaching Center. She serves as an instructor in the diabetes workshops and sees patients individually with a focus on self-management. Crystal comes from an extensive background in cardiothoracic surgery, working in intensive cardiac care units and mechanical circulatory support at UCSF, having received a DAISY Award in 2013. She became interested in diabetes when her now husband, 1 year into dating, was diagnosed with type 1 diabetes. She went on to complete a diabetes nurse fellowship with UCSF and obtained her CDE in 2015. And in 2019, she transitioned to the Diabetes Teaching Center. Crystal received her BS in nursing from the University of Michigan, followed by a master's in international management, economics, and policy from the University of Bocconi in Milan. Following her master's, she worked in Ecuador, supporting the rebuilding of healthcare infrastructure in the border region with Peru. She's proficient and loves speaking Spanish. And upon returning to the US, she worked in advanced heart and lung failure and as a part of the TB program. Welcome, Crystal, and we're looking forward to your presentation.
Hello, my name is Crystal Kovacic. I'm a registered nurse certified diabetes educator, speaking to you today regarding cystic fibrosis-related diabetes self-management considerations. I welcome connecting with you on the networking platform throughout the course of this conference. The following relationships exist related to this presentation. I hold stock in Abbott, AbbVie, and Medtronic corporations. As just presented to you in the prior presentation, cystic fibrosis-related diabetes is a distinct diagnosis. However, it does hold the hallmark characteristics as the hallmark characteristics of type 1 as well as type 2 diabetes. The insulin deficiency that exists in cystic fibrosis-related diabetes originates from scarring from the mucus buildup on the beta cells of the pancreas. The insulin resistance also originates from the mucosal coating of the beta cells, and it is subject to intensify with cystic fibrosis-related treatments such as steroids. Screening and diagnosis, also presented in the prior presentation, are of utmost importance, as it is well known that the insulin deficiency is correlated with clinical decline in pulmonary and nutritional status. The risk of diabetes increases in the general population with age as well as in the cystic fibrosis population. Screening should be completed per the recommendations by oral glucose tolerance testing. Through early identification of glucose intolerance, the benefit is that you can offer and engage with the individual to educate regarding the benefits of early diagnosis and optimal management of diabetes. Take the time to consider involving diabetes educators, certainly registered dietitians that they are already maybe working with within your group, and developing carb counting skills early on. Once glucose intolerance is recognized, avoid liquid carbohydrate intake as it does stress this predicament. Carb counting skills will build confidence and provide the foundation for optimal mealtime insulin dosing in the future in the setting of diabetes. And introducing the monitoring and tracking concepts that will also play a pivotal role in optimal diabetes management. It's a great time to revisit the benefits of exercise, that it increases insulin sensitivity of the individual's own insulin and may actually delay the onset of diabetes. It increases lung function as well as overall build strength and muscle building capacity, which contributes to healthy metabolism and may be particularly important to the adolescent facing onset of diabetes and interested in body image. Carbohydrate counting is the basis of nutritional insulin dosing. Integrating intimate familiarity with nutrition labels, standard 15-gram portion sizes, and the use of food apps in order to do so will take the edge off of the learning that may come later on with the diagnosis of diabetes. Filtering and navigating a label may not be as obvious as you think as healthcare providers. Oftentimes, people do not recognize how many servings are in a container, rather assuming that one container is one serving. So pointing out how many servings in a container is relevant. What is the serving size? How are you going to determine that? What is most practical? Measuring 1 cup or weighing 227 grams on a food scale. The practical measurement usually is the 1 cup. identifying the relevant information to look at when it comes to diabetes, what is going to have an impact on the blood glucose level, the total carbohydrates, and identifying that fiber, total sugars, including naturally occurring or added sugars, are included in that total. And that identifying that the percentage daily value is not relevant, particularly when it comes to diabetes and insulin dosing. Total carbohydrates are also recommended to be adjusted by taking out the fiber and using the net carbohydrate, as the fiber does not get absorbed and will not have an impact on the blood glucose level. Starting with the basics that can help support the building of these carb counting skills. The utilization of measuring cups and identifying what 1 cup of rice looks like on your plate versus 2 cups, or anything in between, which will be the starting point for carbohydrate counting and insulin dosing. Once they're comfortable with the basic identification, then tuning in on more particulars. What is 1 cup packed, which would be a true standard measurement, resulting close to 45 grams of carbohydrate versus a loosely packed cup of brown rice, which could come in under 10 grams of carbohydrate less and have an impact on insulin dosing as well as subsequent glucose response. Weighing food, especially with fruits, 1 small apple may not be very meaningful. 1 small orange, as previously identified. What does that mean? When you weigh the food, you can look at how many grams of carbohydrate are included per ounce of measured weight of that fruit. Multiplying the grams of carbohydrate by the ounce of weight will give you the total grams of carbohydrate. There are many resources, basic as well as through the food apps, which can help support these efforts. The electronic resources commonly used, Calorie King, MyFitnessPal, KingFit, hold the ADA standard recommendation food measurements, as well as those posted by many fast food or commonly used brands. ThigWe is a food app that allows individuals to take a picture of their food and will help them assimilate and identify the total carbohydrate count, as well as just the basic knowledge that chain restaurants are required by law to post their nutritional information either by brochure in the physical location or at least online, and that is always accessible by www.restaurant.com. Once you have the foundation built and ease and familiarity with carb counting, then you can introduce the concept of insulin dosing. There's mealtime insulin, and then there's basal insulin. Carbohydrates are relevant to the mealtime insulin, which is insulin taken before a meal, before or after a meal, based off of physiologic considerations. And that insulin is meant to dispose of carbohydrates consumed during the course of that meal, allowing the sugar to be mobilized and converted into energy within the cells for storage or immediate use. We determine the amounts, the best way to determine the amounts of insulin to be taken with a meal is through the use of carbohydrate ratios, taking 1 unit of insulin, rapid-acting insulin, for every 15 grams of carbohydrate in this example. And this allows for accurate dosing once the needs are identified. Basal insulin is the concept of overnight or in between meal dosing. The combination of basal bolus insulin is to assimilate the natural patterns in our body with blood glucose fluctuations in the setting of eating. Carbohydrates cause the blood glucose to rise. The pancreas would normally pulse out small doses of insulin in order to manage that amount of rise. And this happens at each interval of eating. On the right, you can see the assimilated pattern of basal bolus insulin. The pancreas pulses out small doses of insulin in the background, maintaining a somewhat flat line overnight and between meals. That is the purpose of the long-acting glargine, detamir, or continuous doses of rapid-acting insulin in the setting of insulin pump use, as well as these shorter bursts of insulin delivery around a meal on multiple daily injections. No matter what the origin of diabetes is, at the end of the day, all roads lead to Rome. So no matter what type of diabetes you have, including a multidisciplinary support team is the optimal standard of care to encourage the ongoing development of diabetes self-management education. Diabetes is heavily a self-managed condition, and the better equipped that an individual can be, the more successful everybody will be. The goal is to optimize time in glucose range to achieve a hemoglobin A1C of less than 7 or 8%, depending on concomitant medical considerations as identified by the Diabetes Care and Complications Trial. These cut points limit the risk of long-term microvascular complications. In the setting of continuous glucose monitors, which we will discuss shortly, time in target of 65 to 70% is also becoming a very important piece of the conversation in evaluating how much time people are spending in the optimal glucose range. Tools of the trade to help us achieve these and help the patient achieve these goals are glucose monitoring and insulin delivery systems. First, to look at the glucose monitoring, the standard practice, the basic practice are glucose meters. They are the gold standard. It is recommended when possible to always begin with a basic meter, introducing the concepts of hand hygiene, getting a direct measurement of the glucose from the blood, monitoring to make sure that that information is going to be accurate, checking for expiration dates on strips, adjusting the lancet appropriately so that there's the least amount of pain involved as possible to get the appropriate blood sample. Monitors have also been evolving, and the blood samples are much smaller than they used to be. The recommendations for checking glucose vary in the setting of glucose intolerance versus in diabetes. In the setting of glucose intolerance, we would start with basic considerations to monitor occasionally. Consider checking before a meal using the reference target of less than 115 milligrams per deciliter. Consider checking occasionally after a meal, 1 to 2 hours, looking for the amount of rise, looking for a reference target of less than 160, or whenever the patient might be curious after exercise, perhaps during a course of steroid use, to see how that varies with various activities, or other considerations such as marathon lounging. Diabetes, in the setting of diabetes, the standard recommendation is to check with regularity before meals. The target glucose identified is between 80 and 130. Checking 1 to 2 hours post-meal when assessing for mealtime insulin dosing. It does help providers identify if the insulin dosing is appropriate, looking for that post-meal peak to land somewhere between 130 and 180 milligrams per deciliter. Checking at bedtime, again, to help assess for what's happening between meals to help guide that long-acting insulin, certainly before driving and with any concern for hypoglycemia. Continuous glucose monitors have taken some of the heavy lifting away from the frequent testing through finger puncture. Continuous glucose monitors are devices that are set on top of the skin. This is a Dexcom G6. This is a Abbott FreeStyle Libre. The sensor is placed on top of the skin. There is a filament which goes transdermal and sits in the subcutaneous fat. And it is an indirect measure of glucose through the interstitial fluid. This does result in a delay for the readings. That is another important point of education to communicate with your patients. And it monitors the glucose through a reaction of the interstitial fluid with gluconic acid on the filament, oxygen, and the liquid in the interstitial fluid. Anybody that is on an intensive insulin regimen would certainly benefit from the use of continuous glucose monitors, and they are becoming standard of care in diabetes, especially in the setting of intensive insulin regimens. The eligibility standards as identified by Medicare needing to be reflected in chart notes include checking glucose 4 or more times a day. The individual must be taking 3 or more daily injections of insulin or on a continuous insulin pump, and require frequent insulin adjustments for which this continuous glucose monitor can help provide information and guidance to do so. Looking at what's specifically available today, we've got the FreeStyle Libre, which is an intermittent glucose monitor. As pictured, it sits in the subcutaneous fat and measures continually. However, it is intermittent because the individual needs to take the scanner to the scanner or phone to the sensor in order to obtain the reading. A new version, the version 2.0, was just recently released. It does have alarm options that can be turned on or off. With proximity of the sensor and to the reader, it is not currently available to be utilized with the phone. They will get a notification through continuous communication of an event, either a high or a low blood sugar. They still do need to scan the sensor with the reader in order to get the information in the alarm version 2.0. No calibration of glucose through finger stick is required for this system. The Medtronic Guardian sensor is a 7-day sensor. It is a standalone device offered through Medtronic. The sensor connects to a transmitter, which is a 1-year rechargeable device. Calibration through finger stick verification is required at least twice daily. However, the system works optimally with doing so 3 to 4 times every day. If using as a standalone glucose monitoring device, it does work with the phone. If using with the insulin pump, viewing is not available through the phone, rather through the insulin pump, which I will show you shortly. The Dexcom G6 is a 10-day wearable sensor. It does include a 3-month reusable transmitter. It does not need to be recharged. The charge lasts for 3 months. It does connect with the phone or receiver. Can you download an app on your phone, the G6 app, as well as the Clarity app, which will give more digestible data. No calibration is required for this system. It also does work with an insulin pump, as I will highlight in a few minutes. The 4th available option on the market right now is the Eversense Sensionics implantable sensor. It does need to be placed by a healthcare provider. It does stay in place for 90 days. With each placement, it requires a 24-hour warm-up period. This is the actual sensor. It's less than the width of the diameter of a penny. The sensor communicates through a transmitter, which sticks on the skin, communicates with a mobile app on the phone, and it does require calibration through finger stick twice daily. It is an invasive procedure, which of course adds to the cost. The provider makes a small 5 to 8 millimeter incision, creates a subcutaneous pocket, inserts the sensor, and closes it up with steri strips. And as I said, it has a 24-hour warm-up period and requires 4 calibrations within ideally a 6-hour period of time. Obtaining these devices is an evolving paradigm. It continually seems to be changing for the better. The FreeStyle Libre is covered by Medicare with the aforementioned eligibility guidance. It is covered under durable medical equipment. On commercial plans, it's widely available through the pharmacy and under pharmacy benefits. The Medtronic Guardian sensor is currently not covered by Medicare, either standalone or for use with pump. It is covered by many in commercial plans through durable medical equipment. The Dexcom G6 is also covered under Medicare as durable medical equipment, though can be distributed through pharmacies, just not covered by the pharmacy benefit. On commercial plans, the trend has been to move towards coverage, more frequent coverage under pharmacy benefit. Some plans offer it pharmacy benefit or DMB. It depends. The recommendation is that providers actually order the Dexcom G6 through their electronic medical systems or call in for it to be evaluated as coverage under pharmaceutical benefits. If it's not, then it should be sent on to Dexcom to evaluate for coverage under durable medical equipment. Eversense Sensionics, not covered by Medicare. It is covered under some commercial plans as durable medical equipment. The true benefit of the continuous glucose monitor is that it tells the rest of the story. As I mentioned, the recommendation for checking in the setting of diabetes is before a meal. So maybe you check here at about 8 o'clock, they're going to find that they're in range. They check maybe a little after 2 hours, they're going to find that they're in range again, and so on and so forth. Depending on where you check, you may not be capturing the true peaks and valleys. It also adds many electronic benefit features in order for individuals to tag events that are happening that can help infer what's happening with the correlated glucose response. Insulin dosing, food intake, as you'll see in some markers upcoming. It also reduces the amount of finger stick checks, which I can, with some amount of confidence, say that is the most beneficial aspect for most users of continuous glucose monitors. It also allows for pattern identification, again, which can be useful in for individuals trying to optimize their self-management skills and adjustments of medications, as well as with providers. This data is available to both patients and providers. It has introduced into conversation the time and target versus just identifying highs or lows and not having a sense of with which frequency they are happening. It also does produce an estimated average A1C, which we do find to correlate quite well when the red blood cells are reliable. There are many graph views available that cover the median glucose, include the median glucose average throughout the course of the day, as well as the spread that may occur. And you can see that there's much more variability for this individual earlier in the day than perhaps a little bit later in the afternoon. Again, the spread widens a little bit more at night. It really can help guide treatment recommendations. The average glucose is produced in all of these options in their software, which is usually available, through phone apps or through websites. It will break down the specifications of time and target. It allows for marking with exercise food or alarms that are happening. Here's a little bit more about the breakdown, showing very high how much time is spent above 250, how much time is spent between 180 and 250, how much time is spent in target. The target range is also adjustable. You can raise this lower end to 80 or 90, particularly if this is a vulnerable population at risk for hypoglycemia and you're trying to minimize the amount of time spent in the low or very low range, under 55 milligrams per deciliter. These Continuous glucose monitors are ever evolving along with the insulin delivery systems. We have the most basic to the fanciest options of insulin pumps, which just continue to get more sophisticated. The vial and syringe certainly still is available. Insulin pens, which allow for a bit more clear as well as convenient insulin dosing. These are all options, including a smart pen, which is a stepwise offering somewhere between the basic insulin pen and an insulin pump. It allows for therapy settings to be programmed into an app. This is the InPen offered by Companion Medical. It does communicate from the pen, which is reusable and takes insulin cartridges, communicates to the phone app through Bluetooth. You can adjust therapy settings in 4 time segments throughout the day: breakfast, lunch, dinner, bedtime, and adjust the insulin to carbohydrate ratio, insulin sensitivity factors, and blood glucose targets, as you may want these to change throughout the course of the day. As well as it has programmable duration of insulin action, which then carries forward how much insulin is still active in the system in an effort to prevent insulin stacking and reducing the risk for hypoglycemia from giving rapid-acting insulin too frequently. Insulin pumps are the most advanced option of insulin delivery systems. So of course it depends on the patient's experience, preference, capacity, and needs. Insulin pumps are more nuanced. They do allow for multiple basal rates, continual small pulses in every few minutes over the course of 24 hours. This is used in place of long-acting insulin. It allows for easier insulin bolusing. You often see much more compliance with, or better timing for mealtime insulin when somebody has to press a button on a pump as opposed to go through multiple daily injections, which is another pro as identified by many users. There are adjustable settings that you can make for exercise, reducing insulin delivery with the press of a button, either by percentage or adjusting the blood glucose target. And it just generally allows for a higher capacity of tighter control. The algorithms which are doing this in an automated way are rapidly evolving as well. Cons, of course, there's a learning curve. This is definitely running. Insulin injections are walking, and we all must learn how to walk well and steady on our feet before we can run. There is an added cost associated with insulin pumps, even in the setting of robust insurance coverage. It involves more supply management, oftentimes involving tubing. The pump may be more physically visible. And there is an increased risk of diabetic ketoacidosis, considering that the pumps only use rapid-acting insulin. And so in the setting of pump failure, that can go away more quickly, and you need to ensure that there is an alternative way to get insulin at all times, as well as a higher risk of infection with the indwelling catheters. So insulin management is definitely an art. That art is continuing to get more sophisticated. There are the basic insulin pumps that exist in all pump options on market right now, the Omnipod, the Medtronic, and the Tandem. However, of most interest to most providers are the open loop systems and the closed loop systems. The open loop system correlates with continuous glucose monitor. The insulin pump will take information from the continuous glucose monitor. Based off of the trends, it will suspend and resume insulin delivery accordingly in order to prevent hypoglycemia. This is available through the Medtronic 630G pump, which communicates with the Guardian sensor, and the Tandem Basal IQ pump, which communicates with the Dexcom G6 sensor. The closed loop systems are where everything is headed. The FDA first approved the first system in September of 2012. It was the Medtronic 670G. I'll go into the details next. It was followed by the Tandem Control IQ, which works with the Dexcom G6 in December of last year. There are 2 approvals pending in the FDA that we can anticipate in the next year. They both use the Omnipod. One is through Insulet. It will work with the Dexcom first. Later, it will work with the Libre 2.0. It will be launched from the Android phone system or a personal device, personal management device, as well as Tidepool is another company that's going to follow with another version of a closed loop system using the Omnipod and the Dexcom. Again, the difference is it will launch with the iPhone. There are also non-FDA approved versions out there, namely do-it-yourself looping, which uses Omnipod, or older Medtronic versions. It also works with the Dexcom G6. It is basically an internet document, self-guided, self-built, and primarily supported through social media. The Medtronic 670G system, as noted, was the first system that came out in September of 2017 and made it to market shortly thereafter, working with the Guardian sensor. It has a set target when in auto mode, the automated system, to continually try to adjust the basal rates and offer corrections at various intervals with a target of a blood glucose of 120. It has the capacity to set temporary targets, raising this target to 140 to 160 for exercise. It is a set that includes tubing. There are straight, angled, and steel set options depending on the injection site, infusion site needs and considerations. This is the Tandem Control IQ, the second pump that came to market. It's just approved in December of last year. We started seeing it in January. It works with the Dexcom sensor. You see the reading also on this interface as you do with the Medtronic. The blood glucose target here is a bit more aggressive, 112.5, which was determined to be the minimal risk for frequent hypoglycemia and repetitive hyperglycemia. It also offers options for adjusted targets in the setting of sleep and exercise. It also is a tubing system offering straight, angled, and steel sets. Do-it-yourself looping is the other option available right now. It is a pump either tubeless with the Omnipod or a tubing pump with older Medtronic versions. Again, the app is built by the individual, and it needs this additional Riley link to facilitate communication three-way between the continuous glucose monitor, the phone app, and the pump. Currently, Tidepool is an information platform. It allows everything mentioned that has capacity to connect to the internet or through Bluetooth to be able to be uploaded to the site. This includes basic glucometers, continuous glucose monitors, smart pens, and insulin pumps. It superimposes the information, a continuous glucose monitor, over the pump information, and as well as integrates the carbohydrate as well as ratio information as communicated through each respective device. People can also put in notes, and it is just another piece that facilitates very sophisticated conversation, guiding decision-making for the individual trying to achieve optimal self-management of their diabetes, and in collaboration with their healthcare providers. So thank you very much for your attention. I know it was a lot of information. As I said, I'm happy to connect with you on the networking platform, and I hope something in this presentation was useful to you moving forward. Best of luck, and thank you so much for your time.
Thank you, Crystal, for sharing your expertise and knowledge about educating patients with CFRD. I hope everyone learned something new to take back to your own CF centers and apply it to the self-care management of your patients with CFRD. I certainly know I did. Our next two speakers will be presenting jointly, and they will talk about the importance of cross-training and communication. One of our presenters is Dr. Donna Beth Willey-Courand, and she is the Chief of Division of Pulmonology. She's the Miss Eloise Alexander Distinguished University Chair in Pediatric Pulmonology and the Director of the Pediatric CF Center at the University of Texas Health San Antonio. She received her Bachelor of Science in Chemistry at Duke University and obtained her medical degree at the University of Maryland and attended Baylor College of Medicine for her residency. She completed clinical fellowships simultaneously in biomedical engineering at MIT and pediatric pulmonary at Mass General. Dr. Willey-Courand is currently a member of the CF Foundation's Center Committee. She has received the award of Texas Super Doctor annually since 2011. In 2017, her CF Center received the CF Foundation Quality Care Award, which recognizes outstanding quality improvement processes and accomplishments. She has participated in multiple learning and leadership collaboratives, not only as a participant, but also as a quality improvement coach. She is frequently invited to present on topics related to CF, pathophysiology, pharmacology, and treatment to nurses, pediatric and adult fellows, respiratory therapists, and dentistry students at UTHSA. Dr. Willey-Courand is involved in multi-center drug studies with various CF-specific therapies. Her research expertise is in the care of children with CF, with an investigation of glucose homeostasis in patients with cystic fibrosis with and without CF-related diabetes. Our other presenter is Dr. Maria Reyes. She is an assistant professor in the Department of Pediatrics, Division of Endocrinology and Diabetes. Dr. Reyes received her Bachelor of Science in Psychology from Washington and Lee University and completed her medical school, residency, and fellowship training at the University of Texas San Antonio. She is the endocrinologist dedicated to managing pediatric and adults with cystic fibrosis endocrine disorders and is embedded in both the adult and pediatric CF clinics. She was awarded the 3-year Envision grant by the CF Foundation in 2016 to support her career path and foster opportunities to perform patient-oriented research. She was accepted into the KL2 program at UTHSA in 2020, and this is going to allow her to devote the majority of her time to research that will elucidate the pathogenesis to diabetes development in cystic fibrosis in an effort to improve screening, diagnosis, and treatment practices. In 2014, she and Dr. Willey-Courand published an article called Improved Screening for CF-Related Diabetes by an Integrated Care Team Using an Algorithm. It was published in the Journal of Pediatric Pulmonology. I look forward to hearing the insight this unique duo will be sharing with us today about the development of a collaborative clinical practice. Please welcome Dr. Willey-Courand and Dr. Reyes.
Hello, we'd like to thank the organizers for inviting us to participate in this session today. The title of our presentation is Developing a Cystic Fibrosis Endocrine Clinic. My name is Maria Suki Reyes, and I'm a pediatric endocrinologist at UT Health San Antonio.
I'm Dr. Donna Beth Willey-Courand. I'm a pediatric pulmonologist and the CF Center Director at UT Health.
For our disclosures, I was a recipient of the Envision grant from 2016 to 2019, awarded by the Cystic Fibrosis Foundation to support my career path as a CF endocrinologist.
And I have no relationships to disclose.
We'll occasionally monitor the chat throughout the conference, so please feel free to ask any questions. So why was it important for us to develop a combined CF endocrine program?
As a CF Center Director, at the time we were starting to learn the importance of hyperglycemia and how it impacted the nutrition and the pulmonary health and ultimately the survival of our patients with cystic fibrosis. At that time, I was the CF Center Director in a place where we were really struggling with our nutritional outcomes. We didn't have any consistent guidelines that we were following in our center for screening for glucose abnormalities. When we ordered glucose tolerance tests, our patients were not getting them done, and we didn't have anything established in terms of inpatients and when and how we should screen them. It was really a major issue for us because in San Antonio, over 50% of our CF patients are Hispanic, and the rates of diabetes in that population are much higher. So we thought our patients were even more at risk because of that. The other thing I recognize is that I'm a pediatric pulmonologist, so I live above the diaphragm. And so my knowledge of all the different insulins and when to use them and how to use them and the nuances of using them is about zero. So I needed somebody to help me. I had also learned that we were really not doing well, probably because of a couple of different things. It was a patient issue and it was a provider issue. Our CF patients often no-show to their endocrine clinic appointments. And I think that was in part because they didn't understand the relationship of CF and diabetes and how important it was to get both of them under control. And it was also because they had to go to a different clinic. They had to see another doctor. They had to miss another day of school or work. So that was an additional challenge for our families. And finally, when our patients went to see our endocrinologist, they often were given a message that I wasn't really happy about. And our patients came back saying they just don't understand CF. I had a patient who I had sent there, and this is a perfect example, who was having impaired glucose tolerance issues, and she was growing along the 25th percentile. So I had started her on some nutritional supplements. She was told by the endocrinologist, who was a very smart guy, that she was growing just fine. She was following her own curve, and the reason her sugars were high was because she was taking those supplements. So please stop taking them, and everything will be okay. As you can imagine, that was not the message I wanted my patient to hear.
And from the endocrine perspective, when patients actually did show up to the endocrine clinic, they were confused and thought CFRD was actually type 2 diabetes. And they really wanted to discuss decreasing the carbohydrate intake and the calories instead of starting insulin. And it was pretty evident that neither the patients nor the endocrinologist really appreciated that diabetes was negatively affecting the CF-related outcomes of BMI, FEV1, and mortality. So it was really important for the endocrinologist to be a part of the CF center so that the families really understood that CFRD was a complication of CF and not a new and different diagnosis. So how did we do it?
Well, like any good QI project, you start by recognizing you had a problem. So I sat down with the Pediatric Endocrine Fellowship Director and with Suki, and we talked about the challenges we were experiencing in CF clinic as well as in the endocrine clinic with our patients. And what we decided to do was to embed Suki in the CF center. So for a half day, every single week of her fellowship, she attended CF clinic. And while she was there, she learned all about CF pathophysiology, the therapies that we use to treat our patients, and how the socioeconomic factors that are active in all of their lives impacted their health, their adherence to their therapies, and their outlook about their CF. As important as anything else, is Suki became a member of the CF team. She became part of every discussion about every patient, and she led the discussion about patients and what was going on with them as she understood the nuances of the mental health aspects of CF, the nutritional aspects, and the respiratory aspects of CF care. The other thing we did was we invested in her education, not just in our center, but by sending her to NACFC every single year of her fellowship. We also sent her to learn from the CF experts. Obviously, I wasn't one of them in terms of CF diabetes. And so we sent her to learn from Tony Moran in the middle of a snowstorm. She spent 2 weeks with her, as well as with Andy Kelly, and learned the nuances of screening for CF-related diabetes and managing CF-related diabetes. All of this culminated with Suki taking on glucose tolerance testing in our center, and she developed a QI project, which she published the results of in pediatric pulmonology. It was a great success for our center, and it set up habits that we maintain to these days.
And it was really important, obviously, for me to understand the uniqueness of CF-related diabetes. Although the pathogenesis is not fully elucidated, we understand that it's a progressive insulin insufficiency that's characterized by postprandial hyperglycemia, which interestingly enough, oftentimes happens in the absence of fasting hyperglycemia. And the A1C is falsely low. So I couldn't just screen with an A1C and a fasting glucose like I did in other types of diabetes. And therefore realized how important it was to have the 2-hour oral glucose tolerance test and include a 1-hour oral glucose value as well, because we know that poor lung function is associated with an elevated 1-hour glucose. I also realized the importance of G-tube feeds to optimize nutrition and the need to screen for mid and end G-tube feed blood sugars in the inpatient setting, and then also once a month outpatient, because oftentimes you can have a non-diabetic oral glucose tolerance test, but still have diabetic excursions during G-tube feeds. I also needed to appreciate that there's a whole spectrum of severity with CFRD. Some patients only require a couple units a day, and some require full replacement, like in type 1 diabetes. And there's a variety of insulin regimens that I can choose. Sometimes I just do a long-acting insulin with a few units a day. Sometimes I add a rapid-acting insulin with correction factors and carbohydrate ratios. I use insulin pump therapies with continuous glucose monitoring. I've become very comfortable with using insulins for G-tube feeds, intermediate and fast-acting insulins, and really realized that insulin regimens may vary greatly during a pulmonary exacerbation. So the patients really know that their diabetes can be in flux and they shouldn't really be married to one type of insulin regimen or dose. But then also we realized we weren't just running a CFRD clinic, but patients had other endocrine disorders, including CF-related bone disease, vitamin D deficiencies, adrenal suppression due to chronic inhaled corticosteroid use, that we needed to be well-versed in post-transplant care. And even though we didn't need to be a true CF endocrine expert, we just needed to know where to find the educational resources, like on the CF Foundation website, where the executive summaries have links to guidelines on diabetes, bone disease, and vitamin D. Also, with the Envision grant, the mentees were tasked with writing different topics in a specific endocrine supplement that was published in 2019. So how do we function now?
Well, from my standpoint, Suki's taught me a lot about CF-related diabetes, and I've tried to impart some of that knowledge on our patients, and that is that CF-related diabetes is just part of CF. It's part of the natural evolution of pancreatic dysfunction. And we discuss this with our patients very early on and with their families. We talk about the need to do annual glucose tolerance testing beginning at 10 years of age, but we talk about it at 8 and 9 years of age, and even earlier if a child is having trouble gaining weight. We help the families to understand that poorly controlled blood sugars can lead to worsening nutritional and pulmonary status, and that patients shouldn't try to keep their children from, or families shouldn't try to keep their children from developing diabetes by restricting their carbohydrates. If it's going to happen, it's going to happen. And so they need to make sure they're optimizing nutrition. We also stress that insulin is the only recommended therapy for patients with CF-related diabetes at this time. I think the other thing that's been really helpful for us is that our patients understand that we have a pediatric endocrinologist who's part of our team, that she understands CF, and that we trained her in the world of cystic fibrosis, and that her visits are held jointly with our visits in the CF center, and that we communicate back and forth all the time about patient care issues, so that Suki's viewed as an extension of the CF care team and not just another specialist that they're sent to see. The other thing that we've changed with Suki's role in the team and in the center is how we manage patients when we have to put them on steroids. If it's a patient who has impaired glucose tolerance or who has diabetes, I now warn the families that their sugars are going to go up and that they need to screen more frequently. And I stress to them that it's important, if they see these elevated blood sugars, that they give Suki a call and talk to her about adjusting their insulin regimen. I'll also give Suki a heads up too. I'll either send her a secure health message or give her a call and say, hey, we're going to put so-and-so on steroids. Things may get out of control, so just be prepared. I'm also trying to do a better job in asking about blood sugar control during my visits. I ask patients what their insulin regimen is. I ask them what their fasting blood sugars are and what their middle of the G-tube feeds are, blood sugars are, and we go from there. And if there's an issue, I'll give Suki a call and tell the family that we'll communicate about whether their insulin regimen needs to be changed. And finally, I think with the advent of modulators, especially the triple combination therapies, the world of blood sugar control has kind of been turned on its head. And I warn families now that we've learned that there's patients that have hyperglycemia and patients that have hypoglycemia when they're started on these modulators, and that families should be aware of this risk. I'll also give Suki a heads up and say, hey, we're thinking about starting a triple combination, just so you know, their sugars may get out of control, and she'll preemptively touch base with the families. And as Suki's mentioned, there are other CF-related issues that can happen to other endocrine-related issues that can happen to our patients. And so we referred those, like adrenal issues or growth hormone issues, to Suki also.
So I review all of the oral glucose tolerance test results, and we'll have an in-depth discussion with the patients who have impaired or indeterminate glucose, in which that 1 hour glucose is elevated, but the fasting and the 2 hour are normal. I'll also touch base with them if they're having an uptrending A1C, or if the CF team is concerned about pulmonary or nutritional problems, and we'll screen with finger sticks or continuous glucose monitoring in an outpatient basis. And I also am always talking to the dietitian in regards to nutritional supplements and G-tube formulas, and sometimes we even modify the feeds in terms of changing the formula type if we feel like that might help curbside some of the hyperglycemia.
On the inpatient world, we kind of changed what we do. We actually now have an algorithm that we follow when we admit our patients. All patients get glucose monitoring for the first 48 hours of their admission. They get fasting and 2 hour postprandial. If they're on gastrostomy feeds, we do middle and end gastrostomy feeding measurements. And we notify the endocrine service of every patient with CF-related diabetes that's admitted. But if we have any patients where we're concerned about their blood sugars, whether they've had a diagnosis of CFRD before or not, if there's any issues at all, we give endocrine a call and they come back and see the kid. The other thing that we've learned to do is to stop growth hormone supplementation during the hospitalizations. During a time of pulmonary exacerbations, your body normally doesn't make as much growth hormone. So for our patients that are growth hormone insufficient and are normally getting supplementation at home, we stop that during their admissions to have a more kind of normal physiology when they are in the hospital. The other thing that I've learned from Suki during all of this adventure together over the past 10 years is that every kid with CF, every adult with CF, their pancreas does its own journey. And there's great variability in blood sugars, not only at times of exacerbations, but when girls get their periods. And it evolves with time, and that the glucose tolerance test alone doesn't tell the whole story. You really need to look at the real world experience of these patients. What do their blood sugars do with what their normal diet is at home and in the face of gastrostomy feeds? I've also learned that the world of diabetes management is changing greatly. There's numerous different kinds of insulin. There's insulin pumps, and we're getting ready to start some trials on a bionic pancreas, which is way out of my wheelhouse. So I'm so thankful that Suki's here for that part of our journey. I think Suki and I, as she's mentioned, have really realized the importance of our CF dietitian in the management of our patients with blood sugar issues. They've helped us to learn just what is the carb load of all these supplements that we give in the gastrostomy feeds, and helped us to adjust the feedings as we need to. And in the ever-changing world of these modulators, Suki and I are going on a journey together, learning about how these modulators impact glucose management and glucose stability or instability.
And from an endocrine perspective, a thing that I really learned is I really needed to have my diabetes team. We have a diabetic educator that does all the glucometer, insulin pen, glucagon, carbohydrate teaching, the school orders, helps download continuous glucose monitors and insulin pumps during the clinic. We have our endocrine nurse that comes to the CF center that helps also refill diabetes prescriptions and initiates and follows up on all of the proper paperwork for all of our technology. But it is absolutely important and critical to delineate the responsibilities of the CF team and what the CF nurses are going to do versus the endocrine team, so that everybody is on the same page.
Along the way, we've learned so many things. We've learned that for us, it is ideal to have the patients seen by Suki in the CF center. It's improved their show rates to their endocrine visits, and it's also given Suki the opportunity to interact with the CF team, whether it's the dietitian or the social worker who helps to establish whether the family's got the funds or the insurance that's needed to make sure that they get their diabetes supplies. We also know that we tried to see patients in the diabetes center, and for infection control, that was a real challenge. Obviously, in the world of CF and in the current environment of COVID, we're all really worried about infection control. Well, as you know, in your CF center, that's a core of what you do every single day. Finally, we learned that scheduling a patient in the CF center had a couple of issues. And one was that patients had to understand that they were actually seeing two different doctors in the same place. So they had to have not only the referral to see me, but the referral to see Suki. And that also meant that they got two separate bills, one for her and one for me. We're able to hold our clinic visits either together physically, But in the world of COVID, we've also held it via telephone and by video conferences. And that's really been welcomed by the families as well as the team, because it keeps us all on the same page for patient management. And I think most importantly, the message that we want you guys to hear and that we want our patients to hear is that the pulmonologists and the endocrinologists are delivering the same message about the importance of good nutrition, adherence to prescribed therapies, and that patients need to communicate with both of us about their health issues, and that we need to communicate with each other to make sure that we're optimizing our care plan for our patients.
And our final recommendation is to really train the next generation of fellows in pulmonology and endocrine to carry on this collaboration. We've enjoyed our journey together, and if anybody is thinking of starting off with CF Endocrine Clinic, please reach out to us. Thank you.
Thank you.